Good afternoon, everybody. Welcome to the Mtech Access Words of Wisdom webinar, where each month we're bringing you the latest from inside the NHS, getting to grips with the evolving NHS, exploring the challenges our guests face, how they're responding and how systems are evolving around them. Today, I'm delighted to be joined by Professor Inderjit Singh, who's the Chief Pharmacist at University Hospitals Birmingham NHS Foundation Trust. Indy's worked in clinical and commercial roles within the NHS and now has responsibility for the provision of the pharmacy service within the trust and ensuring appropriate governance of medicines, as well as being an advisor to local and national organisations. I'm going to try and get through as many questions that were sent in advance as we can do, but there was a huge amount sent in, so we'll try and cover the subject matter, but maybe not every question. So Indy, welcome. Thank you for joining me today. Just very quickly, could you summarise your role and your organisation for our audience?
Yes, you said I'm Chief Pharmacist at University Hospitals Birmingham, which is one of the largest trusts in England. We're a four-sided organisation, essentially, four fairly large DGHs. We do a number of specialised services, and we do the full breadth of services since our merger with Heart of England Foundation Trust. So we've got maternity and paediatrics as well, which we didn't have previously.
Yeah, fantastic. Thank you. And in terms of your own role, we had an interesting conversation the other day. Can you give us an idea of your medicines budget and how many items that equates to across the trust?
Yes, so the medicines budget is about 270 million that we're dealing with. I think you're referring to the number of items which are prescribed per month. I've forgotten the figure, but I know it's thousands of items that we do prescribe each month within the organisation, and we are fully electronic prescribing within the organisation as well, which does help with management of prescribing decisions. Yeah,
absolutely. I think it was up at about 300,000 a month, wasn't it? Which I was astounded by. So in terms of how you deliver medicines across the trust then, and locally, I suppose, could you give us a bit of an overview of how the different services work locally? So that's all the hospital services and your other local partners to actually get the medicines out to the patients.
It's an interesting question there, Tom. So, hello?
Yeah, we're still there, Indy. I think we've lost your video, but we've still got your phone.
Apologies, that's finally just disappeared. So the supply of medicine itself is fairly complex, but the use of electronic prescribing does help us significantly with the provision of medicines, because we can see wherever there's missed doses occurred within the organisation, and we are aiming towards a position of 0% consecutive missed doses. So we can understand someone missing one missed dose, but not a second item, because we do hold over 4,000 medications in stock. They also have the challenge of the discharge process and also the outpatient, because on the QE site we used to have 10,000 people a week walking through the doors, and all of that has gone virtual. And of course, with COVID, there's a lot of virtual clinics now, which will continue. I'm not sure if your audience may have seen in HSJ just the other day around the NHS's draft contract was referring to insisting that providers can offer patients an option between virtual or face-to-face, but they're rolling back from that now. As many providers are saying they're not in a position to do that. We've had to change significantly our outpatient model, whereby now 60% of medications are delivered to outpatients. We've had to move from having 2 couriers to having 6 couriers now to support that delivery model, with numerous prescriptions being posted out to patients. That does bring into play the interface with primary care. That has matured significantly during COVID, mainly because of the vaccination programme. We've had to work very collectively together. We've understood each other's pressures and challenges. We still have the challenges of GPs not wanting to take on some prescribing due to the need of a shared care protocol or more information. But with the area of prescribing committee, we have addressed a number of those challenges over the years. We have formal systems in place, so where GPs can escalate back in where they think it's inappropriate prescribing. The key challenge we still have left to address is the new sequence that's come in around providing community pharmacists with discharge information. And that is more of a challenge because of technology. rather than a will to want to do that. But also on the other end, it's understanding that the community pharmacists are aware what they need to do when they receive that information. And it is all around supporting the patients and ensuring they get appropriate counselling, especially with any new medication that they may have received. But medications, everyone says, is the most common intervention in a hospital setting. Invariably, everyone who gets discharged has just received a medication. But what did surprise me, though, from an outpatient setting, only about 12% of patients get a prescribed medication.
Okay.
The majority of outpatients is more consultationary and also reviewing results, etc. As a pharmacist, that did surprise me. I expected the majority of patients to walk out of medicine. But like I said, having seen 10,000 a week, I'm pretty glad that they don't. I think we've got to cope with that aspect of it.
Yeah, absolutely. I mean, that's fascinating. And one thing that you mentioned there is about your 0% consecutive missed doses. How close to that are you? And with not seeing people face to face, has that become a lot harder?
Not necessarily, because with electronic prescribing, you don't necessarily need to be on the ward. So our total missed doses across the organisation are only about 6%. So it's not terribly big in its own right. The consecutive missed doses is at the moment about 1 or 2% that we are dealing with. The challenge is getting the medicine to the ward, but the biggest challenge is the nurse being able to see the medicine in front of her, which seems to be the biggest challenge we have got, because you might send the medicine up, but they still can't find it. So, and it's how do you address that? I know a number of people are saying you go down the electronic carts route, so Pixies, Omnicell, Mediwell, etc. But they're extremely cost prohibitive. But the issue you have there, which most of my senior nurses colleagues are saying, you end up with a queue outside that machine because you've got all the nurses coming up wanting to get all the medicine. Everyone has a 12 o'clock medicine, don't they? They don't stagger them. So there are the challenges associated with those as well. But one way we've started to alleviate that is we've trained up a number of technicians which are actually doing the drug administration on behalf of the nursing staff. So in the organisation, we've got about 16 technicians which are employed full-time on the ward, and their role is to administer medication or support the nurses administer medication. In those wards, we've seen missed doses drop significantly, and consecutive missed doses are at 0%.
Yeah, fantastic. And it's a really good illustration of everyone at the moment is talking about the role technology can play, but it can do a huge amount, but it can't do that last little bit, can it? Or at least not yet, until you've got a robots marching around. But coming back to sort of the way the system's developing, obviously you're doing a lot already with the community, and you mentioned the challenges around sort of getting community pharmacy involved. What do you hope might change in terms of the pharmacy and medicines piece through the development of the ICSs?
For me, it's more complex medicine prescribing happening within primary care. Today, we have the implementation guideline published for the ICSs, but unfortunately, it still reads as though CCGs are going to morph into ICS and provider trust collaborate, but alongside the ICS rather than firmly within the ICS. It's very confusing as to where provider trusts are going to sit within the ICS, and I do sincerely hope this isn't just about moving deck chairs around the system. So when we went from PCGs to CCGs, and we don't want that. We want a full system reform happening. That's what Simon Stevens did promise us at the outset. So in my mind, I'd love to see, especially with the technology we've got now, joint virtual consultations with GPs. So if a GP sees a patient, that they can remotely get a specialist consultation, and they can have the consultation with the patient sat there. They can make a decision there and then whether this warrants a secondary care referral, or whether the GP can be advised to follow a different course of action for that patient before they bounce into secondary care. So what we want to do is to ensure that those who come to secondary care are the most appropriate people, because it's not cheap. As soon as they walk through the door, you get an outpatient attendance cost levied onto that person. So it's around how do we do that within primary care. With the Medicines and Devices Bill that has just gone through the House of Lords and Parliament, there's greater scope around hospital pharmacies dispensing items and sending them to another community pharmacy. The consultation is out in relation to that, but the bill does allow that from a legislation perspective, and that could be transformative, because the difficulty we've always had is giving prescriptions to community pharmacies, they don't have access to the drug. If they do the price, they don't get access to the PAS prices or the other discount prices we have. And fundamentally, they don't keep it in stock. They want to order in a just-in-time manner, which does compromise the patient. And also, not sure how Brexit encourages or discourages this. From a pharma perspective, there's a risk of parallel exporting happening, which is why there's also resistance about providing those agents. So whereas if secondary care was to dispense it and then send it to a local community pharmacy, it reduces my costs in terms of getting drugs out to the patient's home. It ensures that that relationship with the community pharmacist and the patient still remains. And also, from our end, and importantly, it ensures that the community pharmacist can check what other drugs the patient is on and ensure there aren't any interactions which we may not have noticed by not having the full drug history for that patient. Of course, we won't know what over-the-counter medicines that patient is purchasing as well, which that community pharmacist should also have some awareness of.
Yeah, okay. So if you're going down a route like that and you're pushing as much out as you can do, what are the sorts of things that would stay within the trust?
Essentially, one could argue nothing. If you get the model right, you could have a lot of primary care facilitated management of patients. So secondary care really needs to be where there needs to be that specialist face-to-face review that needs to happen, or medication where there needs to be that extra level of monitoring. One that springs to mind immediately is fingolimod, which you have to have cardiac monitoring for 24 hours after the first initiation. But anything else you'd hope we could do from a primary care perspective. And we mustn't forget, for the last 10 years or so, there's been the mandate that you must, if you're going to refurb or build a new hospital, you must have less beds in it and it must be smaller footprint than you were initially. A good example there, Sandal and West Birmingham Trust, which are building the Midland Met, which I believe has got 300 fewer beds than they've got currently, and the footprint is smaller than their current footprint. So the mantra ever since Tricia Hewitt's day and Our Health, Our Care, Our Say has been around that care in the community. What's been lacking is how do you link primary care with secondary care in an efficient manner, and that's always been the challenge with the commissioning agenda we've had. And with the white paper, the intention is to remove the commissioning aspect of it and move to a more of a health economy, and hence why the ICSs have been told they must ensure that their footprint aligns with the LEA. To again remove any of those social and healthcare barriers which may arise.
Yeah, okay. So that's really interesting, because I think one of the barriers to a lot of movements of care has been the perceived need by hospitals, by secondary care, to hold on to certain things. But you're saying in terms of the medicines piece, looking at community IV, at remote monitoring or home monitoring, all of these things, actually you're going to be more proactively looking at ways to enable that movement of care rather than getting rid of the easy stuff and keeping hold of the harder stuff. Is that right?
Well, we already are, because of COVID, a number of trusts have set up what we call virtual wards, where they'll give some monitoring equipment to the patient, which will feed in on a regular basis to the hospital, and they'll do a daily phone call with the patient just to ensure that they're okay. And then they've got triggers for them to bounce back into hospital should they need to. And the concern from patients always has been, yes, I don't mind sitting at home and self-monitoring, but how do I get back into the hospital? That's always been the concern. And so by having the systems in place that allow that, patients are more at ease and they're happier being at home, and that this telemedicine is going to expand. We're doing a lot around artificial intelligence. So we've got a dermatology clinic whereby GP refers into a photographer, want for a better word, where a picture gets taken of the area that there's a concern, and that picture is reviewed from an AI perspective. Then a consultant will also look at that and decide whether we actually need to see that patient or not, whether it's cancerous or whether it's something more serious. And then they can bounce in. If it's not, then they stay out in community. So AI can't be mistaken. With the AI, we have to also remember the genomics agenda, which is getting an aggressive pace now. So we'll have a number of drugs where we will test the patient first to decide which drug is best for them, and that's going to put all of the protocol-driven aspects and all the guidelines fully up in the air. So you'd get some people who would bounce straight to third-tier medication, versus others which would just be first tier based on what the genomic makeup is for that patient.
Yeah, and that's a really interesting area that that certainly we've talked about for a few years, about the art of the possible, and I think there's a perception that maybe it's still a way off. But how close do you think it is before you're using the genomic testing route with a level of frequency?
Well, we already are. There's 2 drugs NHS approved recently, which needs genomics. The National Genomics Programme is just finalising the tender, so we will have all those GMSAs in place. There's JDs already been written for lead pharmacists for each GMSA, so that recruitment should start fairly shortly. But the key thing is to educate all pharmacists and community pharmacists around genomic medicine and how it does work. But then the other element which I go back to is around the artificial intelligence. That's going to build into electronic prescribing systems. So you'll have a position whereby the AI will inform you when you need to do dose adjustments or even change drugs. So if someone's renal function starts to deteriorate or liver function is not where it should be. We've already got a rules-based post in UHB which does semi-do that, but not to the extent we'd like it to. So from a clinical pharmacy could change dramatically going forward, because the AI could even inform you when you're about to prescribe a drug that you need to reduce the dose due to the renal function that the patient's got. But the big element there is around patient record. That's the other barrier we've got. And I know down in South London, King's College Way, they're already scoping this, and we are looking to scope it internally ourselves as well, around how do we get to using this one system, particularly around what we call the clinical portal and the clinical noting. So the GP can see everything the hospital has done, and they would use the same system to record their notes, so the hospital can see what the GP is, and the paramedics can see everything if they ever have to turn up, and then where appropriate, the community pharmacist can also dip in and see that record. Yes, we've got the challenges of Caldecott and GDPR and all those aspects, and it is a concern that patients don't seem to understand. When you come to electronic access of records, they get very concerned, but they don't mind you putting their notes in a taxi and sending them to somewhere else. I think that's completely normal and okay to do. When it becomes electronic, all of a sudden all these firewalls come up, and I think it's not appropriate, because Facebook is going to use it to do something nasty with.
Yeah, okay. In terms of the AI piece then, what you're doing at the moment, or what you're looking at, what kind of data sets can you actually pull on to kind of inform AI? Because I guess there's all sorts of stuff out there that would be really valuable, and having sort of national data would be even better, but what can you realistically use?
This is the thing, we're extremely data rich, so we're already doing a retrospective, so this is around scans and radiology. So we're looking to implement AI into radiology. What we've done is go back to 3 years worth of scans. We've got the AI to review those scans, to review if what the AI says concurs with what we did. Of course, there's a huge governance challenge there we've had to address, which is what if the AI picks up something the consultant didn't, which we should have done, which has led to a detrimental effect for the patient. But we're doing it retrospectively to give the clinicians confidence that when the AI does roll out, that it will roll out successfully. Around medicine, so within our e-prescribing system, we've got all the renal data, liver data, all the UNEs and FBCs that we need. So again, you can retrospectively look at that data and see for the relevant drugs what the impact has been on the renal liver function, if you want to do that, or in terms of dosing, has the dosing been changed at the appropriate juncture? So you could map renal function against dose to see at what stage you should have reduced, and whether they did reduce it or did not reduce it. If they didn't, what was the outcome implications for the patient? Also, you could review if someone decided to change the drug completely. So from a set point, you could see exact date and time a drug change was made, map it back to the patient's use and ease, etc., and see if that was a reason why. And it could be an inappropriate reason, just because they didn't realise that the education piece, that they could actually do something with that drug which would still be safe for the patient. So in terms of types of hypotheses, I think we can answer any question that anyone might have, particularly around drugs and patient. We could go as far as looking at how long someone spent in ICU, what drugs they were on, and when they came out, what ward they went to, and how long they stayed on that ward, and what drugs they were on then, and then how long it took before they got discharged. If someone wanted to say there was a condition in a particular area, we could actually focus on all the patients in the trust at any given time with that condition. But what I really want to do is to is to get this data and compare it with other organisations across the country and just see whether variation in outcomes and prescribing maybe.
Yeah. Absolutely, and I wasn't expecting to talk too much about AI, but I'm going really into it. I could probably do the whole afternoon on it. But before we move on, just one final question, I suppose, in terms of kind of the AI and the automation of prescribing decisions potentially. How does the role of the prescriber evolve alongside that? Is it going to be diminished, or will it just look slightly different?
No, you'll never diminish the role of the prescriber. What you'll end up with is structured-based prescribing. A clinician would still need to sign it off. We're never going to reach a position where the AI would just prescribe and off you go. But what I mean by structured-based prescribing is once you've done your diagnosis and put everything in, that the system would say this is the best treatment option for this patient, and then the consultant would either disagree or agree with that. We already do structure-based prescribing in antimicrobial, so if the results come back the person's got pneumonia and they're not allergic to penicillin, then it will just say, well, this is a structured regimen that you need to prescribe. If they're allergic to penicillin, then this is the regimen that you need to prescribe. So they don't need to think about it. And you could argue that we're maybe dumbing down people, but I think that's the risk of technology anyway. Because most of us now don't even bother to turn our car lights on, do we? Because they just come on. We don't even think about it.
That's why A&E attendances are going back up. We'll move on a little bit now, and this week you've already referenced it. There's a couple of documents, the consultation on the tariff for this year, and also the operational planning guidance. There's a lot in there, obviously, around aligned incentives and new ways of funding things. In terms of the introduction of aligned incentives, what impact do you see that having on medicines and how you do things locally?
The truth of the matter, this is just changing of wording. It is exactly what we're working under since COVID, which is the aligned incentive essentially block. So those drugs sit in the baseline, and we're responsible for the funding associated with those, any that we use. And the other drugs will continue to be in the cost and volume nature of things. And the document makes it very clear early on that they still use the terminology cost and volume. So we are going to work as we have currently been working. And the reason for that, I believe, is that which the implementation document, which published this morning, does make clear, there is going to be elements of specialised prescribing that come down into ICSs. But we don't know what yet, or the extent of that. But the worrying thing with the new contract that they're proposing, there's going to be no opportunity for regional decision making in terms of all the drugs which are passed through, as we call them. That will all be nationally decided upon as to what's done. So we were speaking yesterday with our regional finance leads and clinical leads, and they said they've got no autonomy going forward. Because before we would speak locally, particularly around the incentive piece. Well, how can we be incentivized to support the appropriate prescribing of the pass-through drugs? But all that is going to be a national level, at least for the next 12 months.
Yeah.
But we're waiting with interest to see what they take out of specialised commissioning for into ICS.
Yeah, absolutely. And I suppose my follow-up, because my reading of some of it was that group of pass-through drugs might reduce slightly, and there'll be things from what may be there at the moment that come to you. Is that your reading of it?
It's unknown. If you listen to Simon Stevens from about 4 years ago, his view was NHS should only do the very specialised drugs, so that would be your lysosomal disorders, your CAR-Ts, because he was saying oncology is not specialised anymore, HIV is not specialised, Hep C is not specialised. That can be managed locally. It doesn't need NHS, but the challenge there is how do you prevent postcode prescribing? Yeah. That's the one good thing that has come from NHS and them holding that budget and paying for those drugs. We don't have postcode prescribing anymore. Everyone has access to the same tier of drugs. There is talk about NHS would continue with their specialised circulars, but then how do you ensure that the ICS is adhering to those circulars? Because the temptation would be, what we were back in the 90s, is use the cheapest drugs and delay escalating up to the most appropriate drugs, which is the last thing pharma, I think ourselves, want to see. So I think the devil is going to be in the detail around this as to how this is all going to gel together. But the other key element is, how does the funding change as the value of interactions increases, as activity increases? So if our HIV pool grows, will we get more money to support? Because at the moment, for want of a better word, we've got bottomless pit with NHSE. There's no cap. So it doesn't matter how many HIV patients we've got, or Hep C, or oncology. As long as we're doing the blue tech forms, we're using the appropriate drugs in line with NICE, in line with their commissioning guidelines, we will get paid.
Yeah.
So so that finance piece is going to be extremely interesting and challenging.
Yeah, absolutely. And it's sending my head spinning already. And in terms of that specialised commissioning piece, then those bits that may come your way that aren't there already, that may suddenly appear on your local budget that haven't done, what would that materially mean for you? Will you be looking at those in different ways? Will you be thinking, oh, we're spending a lot on this that we weren't before? Or is it just that kind of thing that, well, we need to prescribe them because they're to avoid the postcode lottery, using whatever framework that might be, and we just kind of got to swallow the cost and catch it up elsewhere?
No, I perceive there'll be more guideline-based prescribing will start to reoccur. You remember we used to have that 20 years ago now, and I think we'll revert back to that with the sole focus, though, ensuring we're not restricting access. Just going to make sure it's appropriate access. And this where you could argue genomics comes back into play.
Yeah.
So you could have genomics supporting that guideline, the patient moving through those guidelines. Because at the moment you get the NHSE service circulars, you get the NICE guidance, there's nothing to join them together and join the dots. And then you also don't have the pathway into those therapies, and that's what we'll have to create to ensure that most appropriate patients do get to that therapy. But also there's going to be an element of discontinuation, ensuring that only patients who are responding continue with it, and we do discontinue as quickly as we can.
Yeah, okay. And I'm just thinking more broadly as well about for every patient that's taking a medicine, some of them will be low-cost medicines, and the medicine is a tiny fraction of their treatment. For others, the medicine will be the largest by quite a significant way of all the care they receive. Will there be a more holistic view for every patient of the package of care that wraps around them and the role of medicine within that? And how do you direct the money in the most effective way?
There has to be, because we have to realize sometimes giving some people some low-cost medicine just delays the inevitable, but also puts them in a more difficult position, and we're using even more expensive drugs to sort out the mess that's being created by the delay. And I think I'm hoping with ICS that we do look at medicines differently and start looking at where we can pump prime and invest to save. So start patients as soon as you wouldn't normally, but knowing that the long-term benefit is going to be greater by doing it in that manner, rather than putting them through sequentially through drugs and nothing more than a cost basis. And that's what those pathways are driven by. We'll start with the very cheapest and just work our way up as the person deteriorates. And the only way we can get there is if we start heading towards 5-year budgets, which hopefully the ICSs could. You may recall NHSE tried a 2-year budget. At one stage we did work well, but really we need to get to a 5-year budget position, then we can start planning for the health of the population.
And would you be looking at medicines differently if you had a 5-year budget?
I think for pharmacy we already do, but it's then getting that and clinicians do as well. But getting the argument back to the payers is always the argument, because of course what we always find challenging, we say to a payer, we need to spend. You spend 2 million now, in 3 years' time, you're going to save 6 million. And for them, it's a 1-year budget. I can't use all that money now in the hope it's going to appear in a different budgetary cycle.
So does the conversation, and it's what a lot of our audience are interested in, is the conversation around the value of medicines and the role that they play. Do you see that is changing around you? People are recognising the value rather than the cost?
I think we're on a journey to get there, but it is a journey. and we have been getting there slowly but surely. And the Hep C was a very good example, whereby different Hep C products were for different people, and we did it. It wasn't as it should be, but an element of genomics with the Hep C product. With HIV, we've semi-done that now as well, where rather than saying all patients go a set pathway, there are different pathways for different patients, and they can have access to different drugs. So I do see that expanding wider with other drugs as well. But it comes back to how do we do that on a national scale to prevent postcode prescribing and ensure equality across England.
Yeah, okay. And what role, we're talking about all the documents that have been published over the last few months, and every time we speak, there seems to be another one. The Commercial Medicines Framework is another one that came out that was intended to drive clinical and cost-effective medicines to patients more quickly. Do you see that having a material impact on how you do things differently, or is it all wrapped up in the same piece?
It is wrapped up in the same piece. I know DH has been promising industry for a very long time around rapid access of medicine, but unfortunately, from a medical viewpoint, we're a very conservative country, and that consultants don't like to use novel therapies very quickly unless they've had some exposure to them. From a legislation perspective, we've got the EAM scheme now, which is allowing drugs to come through quickly through the pathway, and for the first time, we've had 2 drugs recently which, although haven't finished the licensing process, MHRA have supported by EAMS their use within the NHS, which NHS has commissioned. So I think we're delivering on the early access piece. But I think for what pharma wants, which is significant early adoption, I'm not sure whether that will occur. But one thing which is helping is the controlled early exposure to those agents, to select consultants who know their field. And then that knowledge base is helping. But what's really going to help is real life data. So if you can convert that early access into actual real life data that can be extracted out and then shared with the wider community, then that will allow for more prescribers to have the confidence of using those agents. I think everyone is very much so scarred by the likes of thalidomide, which happened in the 70s, but it's still there. That drugs can have adverse implications. And you've only got to look at Europe and AstraZeneca vaccine, haven't you? You know, it's going to clot you up and give you brain hemorrhages if you even dare get injected. So you have to appreciate that they're taking a clinical risk, and also we have to be mindful that most of the trials only have a few hundred patients in, and then you're extrapolating to populations of thousands.
Yeah, absolutely. Yeah. So you've mentioned the real world or real life data. What else do you think might help that those conversations? You mentioned, clinicians are hesitant about novel therapies for, very, very good reasons in most cases. Is there anything else that you think might help give them confidence, or is it kind of that cold hard data that they need to see?
And unfortunately, it's data and discussions with peers. Those are the sole two main elements that they do rely on, and I can fully understand why they do that. Yeah.
Okay, fair enough. The other thing mentioned in the commercial medicines framework is the need for simple commercial arrangements. What does that phrase mean to you, if anything?
That is a phrase that's been pushed for many years, which essentially just means we want a simple discount.
Yeah.
We don't want volume-based agreements. We don't want complex passes whereby you get the first 3 months free, or you get your money back if the patient doesn't respond. I personally think that's the wrong direction, because you haven't commercially, you can't take full advantage of the commercial agenda that's probably available to you, and we have seen a number of cases whereby our overall spend has increased because we just haven't leverage anymore. I can understand why they wish to move in that direction. It makes it easier in terms of the pass-through drug element, because you know what the cost is and everyone's got to pay that price, and it makes it much easier to manage.
The other thing I wanted to touch on with you, in terms of that piece around industry, where do you think industry could and should be supporting at the moment?
This is always a challenging question, and industry always have that conversation with us. And as you know, Tom, my soapbox is build our data. As I strongly believe I'm using a trick with the rollout of electronic prescribing in relation to harnessing that real life data. And I fully appreciate it's difficult to get access to that data, but there must be a way around it by using intermediaries, etc., whereby we can get over that. But the wealth of data now in the NHS is unbelievable, and we've already got the GP data through EMIS, etc., and the other systems that they use. So to be able to align that as well, because the key thing I'd want to see is once we've discharged a patient or from an outpatient setting on a particular medicine regimen, as to how long does that continue in primary care? Is it continuing appropriately?
Yeah, okay. So it's understanding more than just what that particular medicine does, but how is it actually taken? What's the patient experience like? How easy is it for other services to support someone with that medicine? Is that right?
Yes, and also it's all around outcomes now, isn't it? And I think the way you can assess value is by measuring outcomes. So it is a case of, well, how long before that patient bounces back? A classic could be your anti-epileptic medicine as to how long does a patient stay seizure free. Yes, we've got the studies and clinical trials, but we haven't got the real life data. You know, we've got flashing lights and all the other factors in the environment, and how powerful could that be if a drug manufacturer could turn around and say, you know, we've got data which demonstrates 3 years worth of someone not having an epileptic seizure with our agent, and also to be able to put in, there's not been a need for polypharmacy either, because then otherwise one could argue it's because you've added other drugs on, that's why they've stayed seizure free. You'd have all that information to say, well, this was the medicine journey this patient went on, and they may find that where patients have got some adjuvant therapy, they're the ones who are most seizure free. So really shouldn't from day one the patient be started on a combination of 2 or 3 agents rather than just the one agent.
Yeah, I suppose the challenge is
all that data is out there. It's all there for review.
Yeah, I suppose the challenge is who's actually going to start doing those bits of work, isn't it? And that's, I suppose, the challenge you're laying down, isn't it? That the data's there. Who's going to pick through it and find out what it means?
Because the issue is the NHS is data rich, but we're time poor, and we're not getting NHSD or NHSX to do what we'd like them to do. And I'm not really sure what the future of both those organisations is. I know they've got a new lead in those organisations, but I'm not very clear on their direction of travel, because one could argue that's where this piece of work should sit.
And the other thing as well that I suppose plays into that's been referenced is the proposed national medicines registries that I think was mentioned in the in documentation recently. Have you got a view on what that does, what that means, what you could use that for?
I don't, in all honesty. We've got a number of registries already. Most of them tend to be disease focused rather than drug focused. And again, digitally, the consultants put the data in, but what comes out of that, I don't know. A very good example is around Hep C, where NHSE insisted that we collect lots of data. And we've been doing Hep C now for 3 years with the oral agents. I've not seen anything come out just to say anything in terms of this cohort of patients, this is the best regimen to go for, and these you should use these, and for these you shouldn't even use it at all. So it comes back to we're very good at collating all the data, but in terms of analysing it and getting some outcomes out of it, we're very bad at.
Does it feel a bit like we can collect data, therefore we should, and then we'll figure out what to do with it later? But
that's a very good phrase, and it makes me come back to the sites that we've merged with. All pharmacies use a tracker system. So on the QE side, we were only tracking 3-4 types of prescriptions. They were tracking about 15. And I've had that conversation of, you're collating, what are you doing with this data you're collating? And we've rationalized down what they're collating data on to just stuff that you're going to do something with and someone's going to review.
Yeah,
it's a bit like having a filing cabinet full of paper and never opening it for 5 years, and someone wants to throw it away and says, oh, you can't, I need that. But you haven't looked at it for 5 years.
Yeah, absolutely. So, and I suppose for you in a well-resourced hospital trust being unable to do that, the challenge for primary care is even harder, isn't it? That they've got, you know, arguably an even richer data set in some respects, but they're even less likely to be able to do something with it. So how do you see PCNs kind of stepping up in terms of the medicines piece and being able to play a greater role in the whole thing?
So I see under the ICS ban, I do see the informatics piece becoming more and more important. Within our ICS, we already have an informatics work stream that is pushing forward in relation to this. I think for us, it depends on what AI can do in terms of analysing that data and pulling information out. The challenge we have is working with third parties. You've all read in the papers about DeepMind and concerns that people have, but unfortunately we need to work with people like that to be able to get the outcomes that we want, and we've got to get to a position whereby we can reassure the public and government that the data won't be abused and it will be used appropriately and it will still remain the data of the NHS. You can see how financially how extremely valuable this data can be, and hence why there are concerns around it, and also there is concerns around protecting patients' privacy as well, because if this data got into the public domain, you could infer diagnosis and all sorts of things from it, which of course you don't, because with Google now, anyone can see a drug name, Google it and say, oh, that's what's going on with that person. But we've got to address this somehow, and I'm hoping with the ICSs, with working jointly with the government, with NHSX, NHSD, we'll be able to achieve it somehow.
So I suppose flipping on its head and taking the data piece aside for a second, think about it from the patient perspective. What do you see as the greatest opportunities for you to better enable access to the right medicines?
It's not around access, Tom. It's around, what of a better word, patient self-reporting. Because the patient knows what symptoms they've still got or what symptoms are being alleviated. And the ideal would be them being able to feed that data into the NHS, which then gets analysed by AI or something else, which can then say, well, this patient's on the wrong therapy. Diabetes is the easiest one to do. If we could feed in the blood glucose levels straight in, we could pick up very early on. If someone's on oral therapy, we need to either change that oral therapy, or they need to do injectable therapy, or they need to move on to something else. You could argue with thyroxine, etc. That's another good area. I think from a pharmacist, the ideal dream would be an excelled version of the Japanese toilet. You can just sit on it, tells us everything that we need to know about the person, measures your blood pressure, your blood glucose, the whole works really.
Yeah, okay. And
is this something... that's one place we know all patients visit. I don't know how frequently, but there's one place that they all visit.
So we all need tech-enabled toilets. I wasn't expecting tech-enabled toilets to be the answer to that question. But I suppose a big part of that is asking the right questions as well, isn't it? Because the data you get from patients or people taking medicines is only going to be as good as the questions you ask. And often within a consultation, there'll be a set of questions that are asked about a certain set of things, which captures 60%, 90% of the information. But there might be other stuff. How do you capture that?
But this is where AI comes into play, because it will personalize the questions to that patient, A, to the medication they're on, and B, to their responses. So we are rolling out something called Ask A&E, which is a joint project with Babylon Health, which is before someone even phones NHS 111 or walks into our A&E, they have to go into that app and answer questions, and the following questions are all changed based on the response to the first question. Then it will direct them to the most appropriate place, which could be A&E, could be making an appointment with your GP, could be go to your community pharmacy because they've got a PGD and you've got a urinary infection. They can just give you the what you need. Where we're getting to with that, so at the moment we're asking the questions, so stopping them coming into A&E. Where we want that to develop is that if it's saying you need to see your GP, it books the appointment for the GP at a time and date convenient to you. If it says you need to go to community pharmacy, it actually lists the community pharmacies which are open at that time of day and the ones which have got the PGDs to do what you need them to do. So that's the next stage we're working upon, because that's the thing what patients want. It's all well and good sending me to an app, but I want that app ideally to get me to an outcome.
Yeah.
And how amazing could it be if you could book the GP appointment? So the first thing, as a stage one, what we're doing is we're recruiting, I believe it's 14 GPs into the hospital. So we will run a GP clinic, and because it's our clinic, we can ensure that booking system is in that app. So where they need to see a GP, they'll be told you can either see your own GP or you can come into our walk-in centre. This is the next availability, and this is who you will see.
Yeah. Okay. Yeah, it's I'm just thinking, it's got me thinking about all sorts of things, and that kind of gap between the patient experience and maybe the clinical perspective. So in any given conversation, there's two sides to the argument, and they're both talking about the same thing, but with different understanding of the situation. So the patient's thinking, oh, I'm in a lot of pain. The consultant's saying, well, your scan looks fine, so you're clear. And how do you reconcile that? And what can, how do you better support those conversations?
But with something like that, so you tell me I'm in a lot of pain. The first thing AI would say is, when's the last time you took your pain medication? Do you take it regularly? Yes or no? If you take it regularly, what's the interval between the doses? So the first thing you'd look at is the patient concordant with what they're being prescribed. The next thing you would move on to probably is, are you taking anything extra on a PRN basis to augment? And that will then all paint that picture of that pain. Is it down to they're on the wrong medication, or is it concordant? They haven't understood the instructions or the medication where it's saying two, they're only taking one. If they said I'm only taking one, they say, well, why? It could be our side effects. So you can see how, if it develops, you would tease out the answers to the questions you want to be able to determine what is really causing that pain. Yeah.
Okay. So do you see a future where it's and we're already seeing it with 111 and kind of a tech first A&E system that's being brought in, isn't it? So do you see that with anything relating to medicines, that there's a place in the future where you'll be directing people to, this is, ask my pharmacist or whatever you might brand it as in Birmingham, to say, okay, any conversations about your medicines, ask the app, and then it
will. Definitely. I saw a presentation when we could all get in a room together many years ago now. It was like where the Blender Centre had developed, again, it was an AI type app around patient questioning. And there was a patient who presented, who was a cancer patient, and he described eloquently how amazing it was and how it just reduced his anxiety. Because he'd wake up and think of a question like, is medication going to make my hair grow? And he could go on to the Blender app and he'd know the answer straight away. And also it would direct him to further resources. And where need be, where the question was asked where the answer wasn't there, it would say, well, someone will phone you back. And they'd ensure that went to the clinical nurse specialist, who would ensure they phoned the patient back. It totally transformed his patient journey.
Yeah, absolutely. I had a question. It's completely slipped my mind straight out, but it was around that piece. And I suppose that one thing that I didn't get into earlier was that piece around bringing systems together, looking to bring all of these new technologies in and do things differently. how easy is it to get all those stakeholders on board? You mentioned in terms of community pharmacy, it's not the willest.
Again, this is something which we're getting asked a lot, particularly from pharma. But the key thing we have to realise is we're going to be a new entity. So as part of that new entity, we've got to set a foundation, which is mainly a governance foundation and rule engagement. So in my mind, I'm not seeing anything drastically changing for at least 2 years. Because we've got to get the right people in the right places, those relationships developed, those boards developed, the rules of engagement set in place. The statutory legislation itself is not coming in, hopefully, till April next year, and hopefully it will be delayed beyond that. And then sort of 18 months, 2 years, hence, I think that's when you'll start to see things happening, because without the appropriate governance framework in place, we just can't see that. But the key thing as part of the ICS is, what is that GP relationship? I think that's the most important question, because they are independent contractors, but a secondary care viewpoint is, but they're working under NHS contract. So the same way we have locums in hospital, they have to do as we say, because they're working under our contract within our organisation, even though they are independent financially to us. So how do we get to that position whereby the GPs are aligning themselves to the wider health system and are moving in the direction the wider health system wants them to move in, because they're working under an NHS contract? We've got it at the moment where a number of hospitals have taken over PCNs, Wolverhampton, the prime example, Warwick locally, as we have as well, just one practice ourselves. Whether that expands, it's going to be a challenge, because to buy a partner is very expensive, and so juniors aren't coming into that for. But the ideal nirvana would be that all PCNs were owned by the ICS, and everyone within that are employees of the ICS. I know that puts me on a list for GPs too, and Ruby dolls, etc. I think GPs will have
bombarded by emails, Indy. I'm going to be taken off the air, I think.
But I think in their heart of hearts, the GPs also know that is the direction of travel. We need to go in this position of having independent fund holding and independent PCNs. Isn't going to work. They need to integrate with the wider, and the stuff that modality is doing is amazing. What they are doing, they are integrating as much as they can. They're trying to do elements of what we historically see the secondary care within the primary care setting. They're doing a lot more diagnosis that you'd normally see doing in secondary care. And that's where we want to get all primary care to. But I'm also fully aware the medical legal issues that concern GPs. And that's the reason they do bounce people into secondary care. They don't want to miss a test, and they don't want to misdiagnose, and they just don't have the time or the equipment to do what's needed to discount certain things. But to support that, we are actively developing diagnostic centres in primary care. So we've got a unit in Bullring, the main shopping centre in Birmingham, which is going to develop in a diagnostic centre. We're looking at others across the patch. So again, rather than sending to secondary care, you send them to the diagnostic centre to get the diagnostics done, and then we'll determine as a partnership what the next path is for that patient. Yeah,
okay. So I suppose getting towards a lasting thought, well, there's one quick question there, I suppose. In terms of your acquisition of a practice, what was the main driver in that?
For us, we've just taken over what was essentially the walk-in service to ensure it's managed appropriately. So essentially, it was CCG owned that we've taken on. So it wasn't as critical. But I know, Wolverhampton and Warwick have actually taken over GP practices which were in private hands initially. Has to be a rationale, to be honest. I don't know. I believe it's around linking in and having that seamless care, but whether they've achieved that, I truly don't know. Whether they're still acting independently, but the vision is, let's get it while we can, and then we'll integrate as best as we can as we move forward. It'll be very interesting to review their patient journeys versus standard practice patient journeys in terms of referrals into secondary care, outcomes, and even medication usage.
Yeah, fantastic. Thank you. So as a lasting thought, Indy, if you could summarise, I think a lot or most of our audience are interested in kind of the future of medicines in integrated care. So if you could summarise in a sentence, you know, what do you see as the future for medicines in integrated care? How would you sum that up?
I personally do think that the future is bright within IC as long as we get it right and we provide the appropriate support within the primary care setting. I can see more and more specialised medicines being prescribed within primary care and managed within that primary care setting. And the hope is that we will jointly support the GPs with that, and especially with what you've got pharmacists within GP practices and you've got technicians within GP practices as well, that they will also help and support. But also, I'm very keen to ensure that patients escalate up that treatment pathway as quickly as they need to, and that we are able to jump steps and not just say dogmatically, no, you've got to go to this because that's what the piece of paper says, even though the presentation does say maybe for this patient we need to do things a bit differently. So this is where I think getting rid of that commissioning element within primary and secondary, hopefully working as one system, that we can start to deliver for what the health economy in our system needs. I think that's the key thing that Simon Stevens said many years ago, is the needs of all health economies are different because the demographics within that area are different. The population basis is different. So the health inputs need to reflect what that population base needs rather than a national thing, which is what Cough Point essentially was. You will measure everyone's blood pressure and blood sugar. Anyone over 40 or 50, you will do an annual MOT on them. All that needs to change. But I come back to the biggest risk that we face as an IS is becoming a variant and actually restricting access to healthcare. So rather than being at the cutting edge, doing the inappropriate thing, getting back to where we were in the 90s, which was a bad place to be in terms of access to medicines and access to healthcare.
Yeah, absolutely. Fantastic. Thank you very much indeed. We've hit time now, so thanks for joining me this afternoon. It's always a joy to speak with you and really appreciate your time this afternoon. And thank you everyone at home or wherever you are for listening in. Please follow our NHS Whispers page on LinkedIn to stay in touch with all the latest developments. If there's anything that you do want to understand more about what's going on in the NHS at the moment, drop us an email at nhsinsights@mtechaccess.co.uk. Next month, I'll be back on the 30th of April talking about what a place is. It's arguably the most important but possibly least understood part of the new ICS structures. So please join us then. And for now, thank you very much and take care. Bye-bye.
Thank you, Tom.